Hello everyone and welcome to today's discussion on drug dosing in renal impairment. First of all, let us have a brief introduction why a dosage has to be adjusted in case of a renal disease. Renal disease alters the effect of many drugs, especially if the drug is renally cleared. For those drugs which are not renally cleared, they need not be considered for dosage adjustment. In these cases, there are several examples like dimethyl fumarate, which is excreted primarily through lungs as carbon dioxide gas. So, no need for disease dose adjustment in case of patients suffering from renal disease. Second, the drug doses should usually be reduced in renal disease in proportion to the predicted reduction in clearance of the active drug moiety. This can be explained that in different patients suffering from renal disease, there shall be different degrees of renal impairment. That is how, if we measure the clearance by measuring the analyte serum creatinine level, we can get to know the functioning level of the renal, and accordingly the dose of the drug can be reduced to attain a steady state plasma concentration of the drug for maximum efficacy. The patient factors that needs to be considered includes two, that is, as we have already seen, renal impairment. Second factor is the patient size. For an average individual, patient size is taken as 1.73 square meter. The two factors for drug that needs to be considered is fraction excreted unchanged in urine. Second is drug therapeutic index. Estimates of renal function are useful to guide dosing of drugs with medium therapeutic indices, but not precise enough to guide the dosing of drugs with narrow therapeutic index. Estimates of glomerular filtration rate is based on creatinine levels. Serum creatinine is the most common analyte used to estimate renal function. Estimated glomerular filtration rate has the units of milliliter per minute per 1.73 meter square. Both creatinine clearance and drug clearance is measured as ml per minute, that is, volume per unit time. For most of the drugs, the prescribing information that is present in the drug product information leaflet represents a standard dose. Some cases, dosage adjustment for renal diseases is indicated. However, it is imprecise because most of the individuals differ for certain drugs. There is large inter-individual variability observed. Certain drugs, like narrow therapeutic index drugs, have a small change in drug concentration may have a vast impact on clinical efficacy of the drug. For example, tizanidine hydrochloride is a narrow therapeutic index drug that is effective in a very small dosage and a very small duration of time. So, a small change in drug concentration may have a vast impact on the time at which the drug is needed the most and the clinical efficacy of the drug. The other drug with a narrow therapeutic index is lithium. So, the degree of manic depressive episodes cannot be correlated with the exact time of administration of the drug to get the maximum clinical efficacy. So that is why in case of drugs which are eliminated primarily through the kidneys, and if there is renal impairment, coupled with the fact that they are a narrow therapeutic index drug like lithium, a dosage adjustment is very important in case of renal impairment. What is therapeutic index? Therapeutic index is the total duration during which the drug is effective, that is, the minimum toxic dose divided by the maximum effective dose. That means the total duration at which the minimum therapeutic concentration in the blood or the plasma concentration required to initiate drug clinical action to the time the maximum concentration is achieved, beyond which there is toxicity observed. So this is the therapeutic index is calculated mathematically as minimum toxic dose divided by the minimum effective dose. Drug clearance and bioavailability, these two factors determine the steady state plasma concentration of a drug. The bioavailability is the fraction of the drug dose that reaches the systemic circulation whether or not the drug undergoes first pass metabolism. So that is why F or bioavailability is dimensionless. Okay? Whereas the drug clearance has the units of volume per unit time. The equation to calculate the dose based on drug clearance and bioavailability can be represented as dose equal to Cp, that is steady state plasma concentration, into drug clearance, that is Cl, divided by bioavailability. Now, bioavailability is a dimensionless value represented as percentage. Cl is represented as volume per unit time and dose is in mg. Units of this equation will be dose is mg per hour is equal to mg per liter. This is steady state plasma concentration into Cl, that is the clearance, that is liter per hour. Since F is dimensionless, no units have been written for it. So finally we have the units of the equation is mg per hour. From the equation, it can be seen that if Cl is half, the drug dose should be half to keep the drug concentration same. Here as we can see, if the drug dose is half, then if the Cl is half, the drug dose is half in order to keep the Cp same. Thus, if a drug is 100% renally cleared and renal function is half normal, the drug dose should be halved, other things being equal. Very important, other things being equal. Many drugs are inactivated by metabolism in the liver. Hence, doses of metabolized drug do not usually require changing for a renal disease. Obviously, since it is excreted or metabolized by the liver, so renal elimination may be less. That is why there is no dosage adjustment required. This is fraction excreted unchanged is very important factor, drug factor that is used for dosage calculation in case of renal impairment. The fraction excreted unchanged is the proportion of the active drug cleared renally in an average healthy person. The doses of the drug with fraction eliminated unchanged greater than 0.5% should usually be reduced in patients with renal disease. This is particularly important for drugs with an intermediate therapeutic index. We have seen the reason why. Here, the patient dose can be calculated as usual dose into 1 minus Fe, that is fraction eliminated unchanged, plus Fe, fraction eliminated unchanged, into estimated renal function of the patient divided by normal renal function. From this equation, it follows that dose should be reduced in proportion to patient's relative renal function for the drugs that are 100% renally cleared, other things being equal. The calculated dose can usually be rounded to nearest whole or half the tablet, or the dose interval can be changed. Important. The calculated dose from this formula can be rounded off to the nearest whole or half of the tablet, or the dose interval can be changed. When evaluating estimates of renal function for prescribing guidelines, it is important to consider the gold standard of drug effect, or alternatively, the drug concentration. The pharmacokinetic studies in patients with renal disease are usually conducted as a part of pre-registration evaluation. It is mandatory for any ANDA or NDA applicant to do a study pharmacokinetic evaluation in patients whose renal functioning is impaired in order to compare the efficacy of the drug as compared to normal renal functioning. This is very important for those drugs which are used only for renal diseases. Second are narrow therapeutic index drugs. Third are 100% or primarily excreted through the renal route. While not all these studies are published in peer-reviewed journals, the result can usually be obtained from US Food and Drug Administration databases. The drug product information that is provided to a physician and the leaflets that are provided to the patients often have very crude dosing guidelines for renal impairment and sometimes specifically exclude patients with renal impairment, usually because these patients were excluded from primary studies. In these situations, applying the principles of creatinine clearance is the only option if the drug is to be used, and such considerations allow for more appropriate prescribing in many situations. Another factor that causes a primary failure in case of dosage adjustment in case of renal disease is patient compliance. Patient compliance is the greatest cause of therapeutic failure in the treatment of chronic diseases. In prescribing any drug, the possibility of current or future non-compliance with the prescribed regimen should be considered. For example, a low digoxin concentration may be due to either underdosing or appropriate dosing with poor compliance. Here, an estimated GFR together with digoxin concentration helps to discriminate between the two possible causes of the treatment failure. That means the level of the renal failure will be determined by GFR calculation, and the value estimation of therapeutic drug monitoring of digoxin concentration in the blood will help to determine whether the patient is compliant or not. The other factors that also must be considered and influence the elimination in case of renal disease is changes in urine pH and the role of drug transporters for secretion. That brings us to the last topic for discussion, that is, let us conclude what we studied up till now. Renal function is an important physiological variable that predictably affects the pharmacokinetics and hence the clinical effectiveness of some drugs. When prescribing for a patient with decreased renal function, the characteristics of both the patient, that means patient size and renal effectiveness, that is the degree of impairment of the renal function, and two factors of the drug, that is fraction eliminated unchanged and therapeutic index of the drug. So these two factors, each patient side and the drug side, should be considered for dosage adjustment. Drug prescribing protocols do not cover all scenarios, as we have seen. Somewhere they had been avoided. Somewhere, even if the studies are done, they are not up to the mark, especially in case of drugs which shows high degree of inter-individual variability. Understanding and applying principles of good prescribing, such as those outlined in the slides, allow recognition of potential problems, avoidance of drug toxicities, and improvements in treatment efficacy. It's known, obviously, if the renal function is impaired, then elimination of the drug through renal will be impaired. As a result, high concentration will be present in the body for a long time, which may have toxicities. That brings us to the end of the discussion today. Thank you very much for your kind attention.